Next, can I invite Dr. Santosh Mahapatra? He's the Chief Medical Officer at JP130 Eye Hospital, Cuttack, and he's also the Secretary at Odisha Ophthalmic Society. And he's a prolific vitreoretina surgeon there. Dr. Santosh?
Good morning, everyone. I'd like to thank Scientific Committee AIOS, Dr. Santosh Mahapatra and Dr. Pranam to give me the opportunity to talk here. Just as discussed, it's a case-based discussion. So I'd like to discuss the situation, gross diminution of vision in a relatively quiet eye around day 10 to 15 in a post-operative case. So the first case here is a 72-year-old male who has undergone cataract surgery in the right eye 13 days back, presented with visual acuity of counting finger 2 meter in the right eye with mild circumciliary congestion, SC reaction, but gross vitritis. You can see the anterior segment picture is relatively quiet, but the fundus is view is very hazy. You could not appreciate the disc or the blood vessels. So the case was diagnosed as any other case of acute onset postoperative endophthalmitis and advised for vitreous tap and VCD. So post 7 days he was reviewed again, but the vision was not improving. It deteriorated to hand movement. IOP was maintained, but there is decrease in AC reaction because of we have started steroids, but the vitritis is persisting and the vision has decreased. So is it a fungus? We thought, and it was evident on the next visit with you can see this is the first 7 days picture, and this one is after again another 1 week, where you can see typical fungal balls on the fundus just near the posterior pole as well as in the periphery. So he has undertaken for surgery. You can see the anterior segment is still looking quiet, but the vitreous was seeded with multiple snowball opacities around the posterior pole, which is extending to the periphery. As Dr. Deepak was telling, a complete vitrectomy was done, but you can see the balls were not moving. So meticulous care is needed to take out each fungal ball which is stationed over the retina, and you should not leave any snowball because it acts as a nidus, and it is the source. So it's like a culture which is seated on the retina, and each ball can potentiate another course of infection if left. So it needs a meticulous care to go with a fluid needle, take out each fundus spot, because the retina you may injure if you go close with a vitrectomy, and fluid exchange is done. You can see the fundus is very clear. So when the vitreous tap was sent for culture, we KOH mount, we could see the fungal hyphae suggestive of aspergillus. It was on Savarot's agar gave rise to fungal colonies. Another case, post vitrectomy, is reported on day 15. This is the post-op picture. So we'll go to case 2, eventful cataract surgery, phaco undergone, reported on day 18, again a relatively quiet anterior segment, but the fundus was not very clearly visible, only the vessels were appreciated. As discussed, he was again treated as a post-operative endophthalmitis with antibiotics, steroids, cycloplasics, but no improvement. Day 25, the SE now had a clear-cut pupillary membrane sitting over the IOL, and definitely we thought might be dealing with again a fungal endophthalmitis. Taken a BISCAN also correlated and taken up for surgery. So as I said, the lens is you can see there is a very clear-cut membrane over the lens, and we tried to save we succeeded in saving the IOL, and we removed both the anterior and posterior capsule and left the peripheral capsular rim so that the IOL remains stable, but at the same time all the needles of infection in front of the IOL as well as from behind is being cleared, and you can see the vitreous cavity, it was looking innocuous, but on induction of PVD, yes, now you can see that there is a gross, yes, few fungal balls are seen and dense vitritis, which need to be cleared completely. Near complete wax excision need to be done. Repeatedly, we are stressing upon this point because if you leave any needles of infection, your treatment is not successful. So, need to overlay cases with not missing a fungal endophthalmitis, and when we need to suspect the fungal endophthalmitis. You need to suspect fungal endophthalmitis when there is a relatively less edema, but you can see white yellow infiltrates following cataract surgery in the wound, and a hypopyon which is relatively solid, not moving with eye movement and has a convex border, and on vitreous you can see dense vitreous exudate with string of pulse, and creamy white circumscribed chorioretinal lesions can be seen sometimes like this. You can also have associated retinitis or retinochoroiditis, and need to give the proper history to rule out diabetes or other causes of immunosuppression and do a complete laboratory test. So, paracentesis and vitreous biopsy is of paramount importance because you need to cleanse the diagnosis as a fungal origin. So, you also need to sometimes do PCR or SGA agar, and the common positive organisms are Candida or Aspergillus. So, early vitrectomy and complete vitrectomy is the key, along with intravitreal and systemic antifungal drugs. So, my take home message is postoperative fungal endophthalmitis is rare, but yet a vision threatening ocular inflammation, lack of clinical suspicion, and empiric use of corticosteroid without proper antifungal coverage increases the risk of significant vision loss. Early diagnosis, early vitrectomy, and more than one time intravitreal antifungal injection and prompt effective oral antifungal therapy is crucial to manage this kind of cases. Thank you.
Thank you, Dr. Santosh. So, in how many cases did you put silicone oil in any of
in these two cases? It was not needed because they reported very early and operated in our hospital. So, as usual, we call each patient at 7 days for follow-up. So, they were not giving any pain or something, but on examination we could see there is something wrong. The vision has decreased from the day of post of 1, and it was definitely giving a clue. So, in these two cases, IOL removal or silicone oil were not needed. But if you see a case where there is a lot of exudates, there is no clarity, and there is
there may be a
active retinal inflammation, definitely you can consider silicone oil.
Okay. Thank you.
Dr. Santosh, just one query that I have. These fungal endophthalmitis, whether they are of mostly exogenous or endogenous origin?
Following surgery, it is exogenous.
Okay, right.
But we always need to rule out endogenous cause if there is a cause like uncontrolled diabetes or any other cause of immunosuppression, and the patient might have infection somewhere else, which might cause a endogenous endophthalmitis.
Like with patients of diabetes, patients who are immune suppressed.
One of the first patient was a uncontrolled diabetes.
Okay, thank you.
Thank you.